All right, let's unpack this. Welcome to the deep dive. This is where we really cut through all the noise, stack up the sources, and pull out those crucial nuggets of knowledge. We want to give you, our listener, a real shortcut to being truly well-informed. Today, our mission, well, it's pretty ambitious. We're diving incredibly deep into the intricate world of cardiac electrophysiology.
That's right.
We want to understand this field, its core principles, its applications, with the kind of clarity, the confidence you'd expect from the elite professionals who navigate its complexities every single day.
Absolutely.
We're not just scratching the surface here. We're getting right to the core of how our heart truly works. We're pulling insights from Chapter 243, Principles of Clinical Cardiac Electrophysiology, along with its really fascinating figures and some related readings. And make no mistake, understanding the heart's electrical system isn't just, academic. It is absolutely crucial for diagnosing, understanding, and managing rhythm disorders. It's about getting to the heart of the matter, literally, and seeing the genius in its design.
And what's truly fascinating here, I think, is the sheer elegance, the precision of the heart's electrical system. You look at it from the behavior of individual cells, these tiny, incredible engines, all the way up to the integrated, synchronized function of the entire organ. It's quite remarkable.
It really is.
Our journey today will really highlight that evolution. We'll go from those early fundamental observations, starting with basic principles over a century ago, all the way to the incredibly sophisticated high-tech diagnostic tools and, well, the modern interventional therapies we have available now.
Okay.
So this deep dive will systematically cover the historical context, how we got here. Then the foundational cellular mechanisms driving every heartbeat. How those impulses actually propagate, spread through the cardiac tissue in this perfectly choreographed dance. And then critically, the diverse mechanisms that cause arrhythmias, when that rhythm goes wrong and the cutting-edge treatments develop to address them.
Right.
By the end, you should have a really profound integrated grasp of this vital field, giving you, hopefully, a true master's level understanding of its foundational principles.
Excellent. So let's set that historical scene then. Today, we kind of take for granted our ability to monitor and understand the heart's electrical activity. But if you rewind a century, this was completely uncharted territory. How do we even begin to decipher something so incredibly intricate, this hidden electrical symphony within us?
Yeah.
Where did this journey really start?
That's an excellent question, because the foundation, what really allowed us to even begin this journey, was truly laid over a century ago. It was a brilliant Dutch physiologist, Willem Einthoven.
Einthoven, right.
Exactly. He developed what we now know as the modern surface electrocardiogram, or ECG. And this wasn't just a simple device, it was a revolutionary conceptual leap. I mean, imagine, suddenly, doctors and scientists could non-invasively record the electrical potential generated by the heart. They started gaining insights into its rhythm, its overall electrical health. They could even start to understand how electrical abnormalities led to, well, mechanical pumping dysfunction, and crucially, the pathophysiology of various cardiac arrhythmias.
Wow. So before that, it was mostly guesswork.
Largely theoretical, or based on, gross observations. Einthoven's work allowed us to literally see the heart's electrical activity from the outside. It gave us those first broad brushstrokes of its internal workings.
That's incredible. So the ECG gave us the big picture, the sort of external manifestation of the heart's electrical life. But how did we then move from that surface view, from seeing the forest, to understanding what was happening inside the heart? At the level of individual trees, the cellular level, what was that next big leap?
That's where the mid-20th century really comes into play. This period saw monumental advancements that allowed for the direct recording of cellular membrane currents.
Okay, so measuring the cells directly.
Exactly. This was a pivotal step because it provided the profound understanding that the surface ECG, the thing Einthoven developed, is essentially the summation of all the individual cellular electrical activities.
Oh, I see. Like an orchestra.
Precisely.
Yeah.
It's like listening to the complex, beautiful sound of an entire orchestra and suddenly realizing you can isolate and understand the unique contribution of every single instrument. This deeper cellular understanding also coincided with, and really in many ways ushered in, the development of the very first antiarrhythmic drugs.
Right, the first medications.
Yeah. These early drugs aimed to modify those cellular currents to restore normal rhythm. Though their targets were often, broadly understood rather than pinpointed like they are today. But here's where it gets really interesting. The true modern era of clinical cardiac electrophysiology, the interventional side, really kicked off in the 1960s.
Okay.
This was when the first human intracardiac electrogram recordings were performed.
Inside the heart.
Inside the heart. Imagine that putting tiny specialized wires directly inside the heart to record its electrical signals from within. Initially, these invasive electrophysiology studies, or EP studies as we call them, were primarily diagnostic tools.
Just for diagnosis.
Primarily, yes. They were used for, say, serial electrophysiologic testing to carefully evaluate the precise mechanisms of arrhythmias, to assess how effectively various antiarrhythmic drugs were suppressing those arrhythmias, and even for programmed electrical stimulation of the heart to stratify risk for sudden cardiac death in certain high-risk patients.
That sounds incredibly invasive just for diagnosis alone. What about treatment back then? If they could diagnose these complex electrical problems from the inside, what could they actually do to fix them?
Yeah, that was the key limitation of that early period. In the 1960s and 1970s, if you needed an invasive treatment for a cardiac arrhythmia, your only real option was open cardiac surgery.
Open heart surgery. Wow.
Yes. For example, if you had an accessory pathway, that's an extra electrical connection in the heart causing a dangerously fast heart rate surgeons would literally have to open the chest and heart to, well, ligate or cut that pathway.
A major undertaking.
Huge, high risk, limited to only the most severe cases in specialized centers. But then came the true game changer, the watershed moment, the 1980s. This decade saw the development and widespread adoption of radiofrequency catheter ablation.
Ablation, even.
This was absolutely revolutionary because it allowed for therapeutic intervention without open surgery.
Minimally invasive.
Exactly. Instead of opening the chest, a tiny, flexible catheter could be guided precisely to the problematic electrical spot inside the heart. Using radiofrequency energy, it could then create a tiny, targeted burn, a permanent lesion, to eliminate the source of the arrhythmia. This innovation single-handedly ushered in the era of interventional cardiac electrophysiology. It transformed the field from primarily diagnostic to, in many cases, curative.
So we're talking about minimally invasive ways to actually fix the electrical problem.
Yeah.
That's not just a huge leap. That's an entirely new frontier in treating heart conditions.
Absolutely. And simultaneously, alongside catheter ablation, came the advent of sophisticated, reliable, implanted cardiac rhythm management devices, things like pacemakers, and later advanced implantable cardioverter defibrillators, or ICDs.
Pacemakers and ICDs, right?
These developments together solidified clinical cardiac electrophysiology as its own distinct, specialized medical subspecialty. Before this, it was more of a general cardiology interest, These advancements, both interventional and device-based, created a dedicated field solely focused on the intricate electrical system of the heart.
That makes sense.
So if we connect this to the bigger picture, it's truly remarkable to witness this rapid transformative evolution. I mean, think about it. From Einthoven's basic observations of surface electrical activity over 100 years ago, to understanding the individual cellular currents, then developing the ability to pinpoint and ablate specific problematic circuits, or implant advanced devices that can deliver life-saving therapy directly to the heart. It's a testament to relentless scientific inquiry and medical innovation moving at an incredible pace, constantly building on previous knowledge to achieve highly sophisticated, often life-changing interventions. The story of cardiac electrophysiology is really a profound narrative of discovery and mastery.
It really puts the scope and mastery of this field into perspective. Okay, so from that broad historical sweep, let's zoom all the way down now to the foundational science. Every single heartbeat, every pump of blood begins at a microscopic level. So how does a single heart cell actually create an electrical impulse? What's happening inside that tiny cell to spark a heartbeat?
Right. To understand that, we need to talk about the cardiac action potential, or AP. This action potential is the fundamental electrical event that drives the entire electrophysiologic behavior of every single cardiac myocyte, every heart muscle cell. Visually, the action potential is characterized by 5 distinct phases. They're labeled 0 through 4, and you can see this clearly depicted in figure 243-1A. Each of these phases corresponds to very specific changes in the cell's membrane potential, all driven by the precise orchestrated movement of charged particles ions across the cell membrane. It's like a tiny, perfectly timed electrical surge within each cell.
And this cellular event connects to the ECG.
Exactly. What's crucial to understand is how this internal cellular event translates to what we see on an ECG. The collective ventricular action potentials are largely what account for the big QRS complex and the T wave on a surface ECG. So each phase of that tiny ventricular cell's action potential directly corresponds to distinct visible phases you see on the ECG tracing.
Okay, walk us through those phases. What are the ions doing?
Let's do it, thinking about the stance of ions. First, phase 0, the rapid upstroke. This is where the cell rapidly depolarizes. Its inside quickly becomes positive. Now, in the main pumping chambers, the atrial and ventricular myocytes, this surge is predominantly driven by a rapid influx, a real rush of sodium ions, not plus, through specific channels.
Sodium rushes in.
Right. But interestingly, in the heart's natural pacemaker and relay stations, the SA and AV nodes, this rapid upstroke is instead dominated by a slower influx of calcium ions, Ca2+, through different channels.
So different ions in different places.
Precisely. And on the surface, ECG, this rapid depolarization in the ventricles corresponds directly to that prominent QRS deflection.
Okay. Phase 0 is the QRS. What's next?
Next is phase 1, early repolarization. This is a brief, transient dip downwards immediately following that initial surge. It involves the rapid inactivation or closing of those sodium channels that caused phase 0, and also the activation of certain potassium channels, which let potassium ions K+, briefly flow out. This causes that slight dip in the membrane potential.
A little dip.
Then comes phase 2, the plateau phase. This is a sustained period where the cell remains depolarized, its inside stays positive. During this phase, there's a really delicate balance going on. Repolarizing potassium currents are trying to bring the cell back to rest, but simultaneously, there's a sustained influx of calcium ions through L-type calcium channels, which are keeping the cell depolarized.
So calcium keeps it positive.
It helps maintain that plateau, yeah. This balance keeps the membrane potential relatively flat, depolarized like holding a note in a song. On the surface ECG, this plateau phase largely accounts for the flat ST segment.
ST segment. Okay, then it must come back down.
Exactly. That's phase 3, late repolarization. This is where the cell rapidly repolarizes, its inside returns to its negative resting potential. This is primarily driven by the inactivation or closing of those calcium channels that sustain the plateau, combined with the persistent and increasing outflow of various potassium ions through specific potassium channels. These let potassium ions flow out, making the inside negative again.
Potassium flows out, cell resets.
Right. And on the surface ECG, this phase corresponds to the T wave.
The T wave. Okay, almost done. Phase 4.
Finally, phase 4, diastole or the resting potential. Now, in atrial and ventricular myocytes, this is a period where ionic currents are relatively quiet. The cell is at its most negative resting potential, essentially waiting for the next electrical impulse to trigger another action potential.
Just waiting.
In those cells, yes. But crucially, in nodal tissues like the SA node, phase 4 is characterized by a gradual, spontaneous depolarization. This slow upward electrical drift eventually reaches a threshold, automatically triggering the next action potential. This is what sets the heart's natural rhythm.
That's the pacemaker part.
Exactly. And on the surface ECG, phase 4 corresponds to the isoelectric segment, the flat line between the end of the T wave and the beginning of the next QRS deflection.
That's incredibly detailed. It really is like seeing the heartbeat under a microscope.
Yeah.
So these ionic currents are ions moving through specialized channels. Tell us more about these ion channels themselves. What are they, and how do they work as the actual molecular engines of the heartbeat?
Excellent point. The precise and varied action of potential shapes we just described are the result of incredibly precise and carefully timed sequences of opening, closing, and inactivation of a vast array of tiny gates on the cell membrane. These are called ion channels.
Oh, good gates.
Think of them as sophisticated molecular machines, yeah. These channels respond dynamically to various signals. Changes in the cell's electrical charge itself, specific molecules or ligands binding to them, or even physical membrane stretch. When an ion channel is open, it creates a tiny selective pathway, allowing specific charged ions to flow through a central pore. This flow creates the electrical currents that, in turn, drive the action potential through its various phases.
Does it take energy?
It does, indirectly. This movement of ions isn't simply passive. The flow of a particular ion across the membrane is ultimately driven by larger molecular pumps or transporters and exchangers. These are often powered by ATP, the energy currency of the cell, like little battery packs. So it's an energy-dependent process, constantly working to maintain the precise concentration gradients of ions across the cell membrane. This constant work is absolutely crucial for these channels to function correctly and for the cell to be ready for the next heartbeat. Figure 2432 gives a nice illustration of the complex structure of these channels.
So they're complex proteins acting like microscopic bouncers at a club, letting only certain ions in and out. What do they actually look like structurally, and how do they achieve this incredible selectivity and control?
Indeed, they are truly sophisticated molecular machines. Ion channels are complex, multi-subunit transmembrane glycoproteins. That means they're large proteins spanning the entire cell membrane, often made of several distinct subunits working together, and they even have carbohydrate chains attached. They typically contain three key components. First, a central pore. This is the pathway through which ions flow. Critically, this pore is incredibly selective for particular types of ions. This selectivity is determined by specific amino acids lining the pore, ensuring only the correct ions pass through, like a very specific keyhole.
Okay, the pore.
Second, a gating apparatus. This is the part that acts like the gate itself, precisely regulating when the channel opens, closes, or inactivates. This precise gating ensures ions flow only exactly when and where needed.
Gate mechanism.
And third, often one or more regulatory subunits. These are often present alongside the main pore-forming subunits and help to, well, modulate the channel's overall activity and how it's expressed on the cell surface.
How do these gates actually open and close? What triggers them?
That's fascinating and fundamental. Most channels gate in response to changes in membrane potential. We call these voltage-gated channels. In these, a specific part of the protein acts like a voltage sensor. It shifts its position when the cell's electrical charge changes, and that physically opens or closes the channel.
So electricity opens the gate.
In many cases, yes. Other channels are ligand activated, meaning a specific molecule or chemical signal has to bind to the channel to open or close it, like a key fitting into a lock. And some are even stretch activated, where physical stretching or deformation of the cell membrane can trigger their opening.
Wow, multiple triggers.
Yes, and decades of basic electrophysiologic study using incredibly precise tools like voltage clamp and patch clamp techniques, and more recently, advanced molecular, genetic, and structural techniques like crystallography have allowed us to understand the incredibly precise molecular underpinnings of these functions. It's a testament to how far we've come from just watching ECGs. The deeper we look, the more intricate it all appears.
That's a true deep dive into the molecular machinery. Now, you mentioned sodium, calcium, and potassium channels earlier as key players. Can you elaborate on their specific, distinct contributions to the action potential? And importantly, what are the clinical implications when these channels don't work right?
Absolutely. Their distinct roles are crucial both for normal function and for understanding disease. Let's break it down. Sodium, Ni+, and calcium, Ca2+, channels. These channels are responsible for most of the inward or depolarizing currents in cardiac myocytes. They respond to the cell's depolarization by rapidly opening, then relatively rapidly closing, and then inactivating. This rapid sequence is precisely what drives that initial steep phase zero depolarization, the electrical spark of the action potential.
They spark channels.
You could say that. Then, potassium K+ channels. In contrast, potassium channels account for most of the repolarizing currents. Their relatively slow opening, combined with the closing and inactivation of the sodium and calcium channels, drives the plateau phase, phases 1, 2, and significantly, the repolarizing phase 3 of the action potential. They're essential for resetting the cell, getting it ready for the next beat.
The reset channels.
Yeah.
And when they malfunction.
The clinical relevance is profound. For example, mutations in specific potassium channel types are a common cause of many inherited channelopathies.
Channelopathies, diseases of the channels.
Exactly. Genetic conditions where the ion channels don't function properly. A classic example is mutations that inherently delay the closing or inactivation of these potassium channels. This results in a prolongation of the QT interval on the ECG, leading to many forms of inherited long QT syndrome.
Long QT, I've heard of that.
Yes, and it can predispose individuals to dangerous and potentially life-threatening arrhythmias. It's a clear example of how a microscopic malfunction in a tiny protein gate can have a macroscopic critical impact on the whole heart's rhythm.
So you mentioned earlier that the action potential might look a little different depending on the specific region of the heart. Does this regional difference impact how drugs work?
Precisely. The shape and functional properties of action potentials do vary significantly across different regions of the heart. These variations stem from differences in the specific recipes of ion channels expressed in those regions, and consequently the active ionic currents present during each phase.
Different recipes.
Yeah. For instance, in atrial and ventricular myocytes, Those pumping muscle cells, sodium channels, primarily dominate the rapid upstroke of phase zero, giving them that very fast, sharp electrical kick. However, in nodal tissues like the SA and AV nodes, it's calcium channels that activate more slowly and dominate phase zero, giving them a slower, more deliberate electrical impulse.
And this affects drugs.
Directly. It explains why drugs that bind and block cardiac sodium channels are effective in treating fast arrhythmias arising from the atria and ventricles, where sodium channels are key for that rapid depolarization. Conversely, calcium channel blocking agents demonstrate their efficacy primarily at nodal tissues, where calcium currents are the main drivers of the action potential. So they're useful for slowing heart rate or blocking impulses through the AV node.
Makes sense. Target the dominant channel.
Exactly. And another interesting regional difference is during phase 4, that resting or pre-depolarizing phase. In atrial and ventricular myocytes, ionic currents are relatively quiet then. The cells are just waiting. But in sinus nodal tissues, you see that gradual, spontaneous depolarization during phase 4 until threshold is reached, initiating the next beat automatically.
The pacemaker function again.
Right. And this depolarizing current in nodal tissues is generated by a semi-selective sodium-calcium channel, famously known as the funny current, or IF.
The funny current.
Yes, it's called that because its behavior was somewhat unusual compared to other channels discovered at the time. And this funny current is actually a direct target for certain drugs, designed specifically to slow heart rate by dampening that automatic rhythm generation.
Fascinating. And finally, just to tie this all back to what we see on the ECG again, can you recap how each part of this intricate cellular action potential translates to what a doctor actually sees on a 12-lead ECG? This the aha moment connecting the microscopic to the macroscopic view.
Of course. Let's look at figure 243-1b again in our minds, seeing the whole orchestra play out on the ECG strip, the P wave. That represents the electrical activation and depolarization of the atria. It's the sum of the action potentials of all the atrial myocardial cells firing, sort of the prelude.
Atrial depolarization.
P wave.
Okay.
Then the PR interval. This reflects the time it takes for the electrical impulse to travel from the atria down to the ventricles. A significant portion of this interval is the relatively slow conduction time through the AV node, that critical electrical gate.
The AV node delay.
Exactly. While the AV node cell's individual action potentials aren't big enough to make a distinct wave on the surface ECG, their sequential activation makes up this interval time.
Got it. PR interval is travel time, mostly AV node. Then the big spike.
Right, the QRS complex. That's the large, sharp deflection. It represents the rapid and highly coordinated ventricular action potentials, reflecting the sequence of ventricular tissue activation spreading through those big muscles. Its shape and width tell us a lot about how the ventricles are depolarizing.
Ventricular depolarization, QRS. Then the flat part.
That's the ST segment, the flat isoelectric line immediately following the QRS. This segment is predominantly determined by the plateau phase, phase 2, of the ventricular action potential, where that balance of inward and outward currents maintains depolarization before the big reset.
Plateau phase, ST segment.
Okay.
And the wave after that.
That's the T wave, the broad, rounded wave following the ST segment. This corresponds largely to ventricular repolarization, phase 3, as the ventricular cells reset their electrical charge and prepare for the next beat.
Ventricular reset, T wave. And the flat line after the T wave.
Finally, the isoelectric segment between the end of the T wave and the next P wave or QRS complex, that represents the electrically neutral phase 4 of the ventricular action potential, where the cells are at rest, fully charged, and awaiting the next signal from above.
Perfect. That's a fantastic synthesis connecting the cellular dance to the surface ECG. Truly connects the dots. Now, we've talked about how a single cell generates an impulse. Here's where it gets really interesting, as you said earlier. How does that electrical signal then spread through the entire heart, ensuring a coordinated, synchronized beat? This is the heart's electrical highway, right? The conduction system.
Exactly. This is where the magic of coordinated contraction truly lies, ensuring every part beats in perfect harmony. The normal cardiac impulse initiates and travels through a highly specialized sort of insulated network of fibers, the cardiac conduction system. Think of it as the heart's dedicated electrical wiring.
The wiring. Okay, where does it start?
The journey begins at the sinoatrial SA node, often called the heart's natural pacemaker. It's strategically located right at the lateral junction between the superior vena cava, the big vein bringing blood from the upper body, and the right atrium.
The pacemaker.
What makes the SA nodal tissues unique is their inherent automaticity. They reliably and rhythmically generate electrical impulses spontaneously, setting the fundamental heart rate. They are essentially the conductor of the heart's symphony.
So it's the SA node controlling the heart rate? But we know our heart rate changes constantly resting, exercising. How does the body control this incredibly important pacemaker?
That's where the autonomic nervous system comes in with its precise and dynamic control. Both the SA node and the crucial AV node are richly innervated by these autonomic nerve fibers. This allows the central nervous system to finely tune heart rate and overall cardiac function based on our body's needs.
So nerves controlling the nodes. How?
There are two main branches. First, parasympathetic input. When you're resting, calm, recovered, the parasympathetic nervous system dominates. This involves the local release of a chemical messenger called acetylcholine, or ACT. XC binds to specific channels on the SA nodal cells, causing certain potassium channels to open. This leads to potassium ions flowing out of the cell. This makes the SA nodal cells more negative inside hyperpolarized, and crucially, it slows down that spontaneous phase 4 depolarization we talked about.
Makes it harder to fire.
Effectively, yes. The net effect is a slower automaticity rate and thus a slower heart rate. Typical of a restful state, it's like gently applying the brakes.
Okay, the brakes. What about the gas pedal?
That's the sympathetic input. When you're exercising, stressed, excited, the sympathetic nervous system takes over. It releases stress hormones like adrenaline, also known as catecholamines.
Adrenaline.
These catecholamines activate specific receptors on the SA node. This leads to the activation of L-type calcium channels, causing an influx of calcium ions into the cell. This influx enhances the rate of depolarization during phase 4, thereby increasing the automaticity rate and speeding up the heart. It's like hitting the accelerator.
Calcium speeds it up.
Correct. The heart rate at any given moment is this dynamic minute-to-minute balance between these two opposing forces, the brakes and the accelerator. The normal range of SA node automaticity rates is actually quite wide, maybe 30 to 220 beats per minute, covering the typical healthy sinus rhythms.
Wow, 30 to 220.
Yeah. In a resting state, parasympathetic input usually dominates, keeping our heart rate lower. Interestingly, the intrinsic heart rate, or IHR, that's the native automaticity rate of the SA node without any autonomic input, is typically around 100 beats per minute.
So our bodies actively slow it down at rest.
Exactly. It highlights how much the parasympathetic system typically slows our resting heart rate down from its natural, unchecked pace.
Okay, so the SA node fires under autonomic control. What happens next? How does that impulse actually get to the rest of the heart, starting with the atria?
Once the impulse fires in the SA node, it travels rapidly across the right atrium, then over to the left atrium. It largely uses preferential conduction pathways. Think of them as express lanes within the atrial muscle. This coordinated atrial depolarization is what initiates atrial systole, the contraction of the atria, which efficiently pushes blood down into the ventricles just before they pump.
Atrial contract first. Then
the impulse arrives at the AV node, atrioventricular node. This is a critical control point. Conduction here occurs relatively slowly compared to other parts of the heart. This physiological delay in the AV node serves two absolutely crucial purposes.
a built-in delay. Why?
First, physiologic AV synchrony. It ensures that the atria contract and finish pushing blood into the ventricles before the ventricles contract. This allows for optimal ventricular filling and therefore efficient cardiac output. It's like a perfectly timed pause in a relay race, making sure the next runner is ready before the baton is passed.
Timing is everything.
Absolutely. Second, ECG reflection. This crucial conduction time through the AV node is clearly reflected on the surface ECG as the PR interval, that time between atrial start and ventricular start. And just like the SA node, the AV node also responds exquisitely to autonomic input. With exercise, increased adrenaline, the PR interval physiologically shortens, speeding up transmission through the node.
So the delay can change too.
Yes. And it's vital to remember, in a normal, healthy heart, the AV node serves as the only electrical connection, the only bridge between the atria and the ventricles. This anatomical gatekeeper is essential. It prevents rapid, uncontrolled electrical impulses from the atria from just flooding down and overwhelming the ventricles, which could cause dangerous rhythms.
The only way through. That's important. Okay, so after that critical control delay at the AV node, it's time for the powerful ventricles to fire. How does that signal get distributed so quickly and efficiently throughout such a large muscle mass to ensure a synchronized, powerful contraction?
Right. After the AV node, the impulse accelerates dramatically. It enters a highly specialized network designed for rapid, widespread distribution, the ventricular conduction system. These are the express lanes for ventricular activation.
There's lanes, okay.
First, the impulse travels through the bundle of His. This then quickly divides into a right bundle branch and a left bundle branch, efficiently taking the impulse towards the respective right and left ventricles.
Right and left bundles.
The left bundle branch further divides into left anterior and left posterior fascicles, like sub-branches going front and back.
Fascicles.
And these fascicles then branch out into a dense, intricate network of specialized fibers called Purkinje fibers. These line the inner surface of the ventricles.
Purkinje fibers. They sound fast.
They are incredibly fast. What's truly remarkable about Purkinje fibers is their conduction velocity. Electrical impulses travel much, much faster in these fibers, maybe 2 to 3 meters per second. Compare that to typical myocardial cells, where conduction is only about 0.3 to 0.4 meters per second.
Wow, that's a huge difference. Why so fast?
It's partly due to the specific types of proteins called connexins in the gap junctions, the connections between these Purkinje cells. They facilitate incredibly rapid ion exchange between cells, letting the electrical signal just zip along.
Better connections?
Essentially, yes. And this endocardially located network of highly conductive Purkinje fibers serves one vital purpose: to rapidly transmit depolarization throughout both ventricles simultaneously. This ensures that myocardial depolarization, and consequently the mechanical contraction, occurs rapidly and in a highly coordinated, synchronized fashion. This synchronization is absolutely critical for optimizing the mechanical squeeze of the ventricles, allowing them to efficiently pump blood out to the body. It's really a masterclass in biological engineering.
Amazing coordination. What about the reset phase in the ventricles? Repolarization.
Good point. After the ventricles contract, they must repolarize, reset their electrical charge for the next beat. Repolarization of the ventricular myocardium actually occurs relatively slowly, and typically it progresses from the epicardial surface, the outer layer, back toward the endocardium, the inner layer.
Outside-in reset.
Generally, yes. This specific, organized sequence of repolarization is why the T-wave inscription in most ECG leads is usually concordant with the QRS complex, meaning it points in the same general direction. It reflects a normal, healthy repolarization pattern that's essential for the next synchronized beat.
That's a masterful breakdown of the heart's electrical choreography, a truly perfectly orchestrated system. But this raises the important question. What happens when this perfectly synchronized, precisely timed electrical system goes awry? What are the underlying mechanisms behind cardiac arrhythmias, these disruptions in rhythm?
Right. When that exquisite precision is disrupted, we see cardiac arrhythmias. These are essentially manifestations of abnormalities in either the initiation or the propagation of the cardiac electrical impulse, or sometimes both. We broadly categorize them into two main types: bradyarrhythmias, which are abnormally slow heart rhythms,
Slow.
and tachyarrhythmias, which are abnormally fast heart rhythms.
Too fast. Okay. Let's start with slow. Bradyarrhythmias.
Yes. Bradyarrhythmias most commonly arise from abnormalities within the specialized conduction tissues themselves. For example, if the SA node, the natural pacemaker, isn't functioning properly, it can lead to what's called pathologic sinus bradycardia, a heart rate that's simply too slow for the body's needs.
Pacemaker failure.
Or similarly, disease affecting the AV node can result in a conduction block. This means the electrical impulse struggles or fails entirely to get from the atria down to the ventricles. Pathology in the His-Purkinje system, those fast expressways in the ventricles, can also cause conduction block, preventing the efficient, synchronized spread of the impulse through the ventricles, leads to a slow ventricular rate.
Blockages in the wiring. Got it.
Got it.
What about the fast ones? Tachyarrhythmias.
Now, tachyarrhythmias are often more complex in their origins. They can arise from nearly any location within the conduction tissues or directly within the atrial or ventricular myocardial tissues themselves. They're typically classified by their underlying mechanism, and understanding these mechanisms is absolutely key to effective diagnosis and treatment. There are three primary mechanisms we really need to discuss, and these are beautifully summarized in Table 243-1 and visually depicted in Figure 243-3.
Okay, three main ways things can go too fast. What's the first one?
The first mechanism is enhanced automaticity, sometimes also called abnormal automaticity mechanism. Remember how we said pacemaker cells, like the SA node, have normal automaticity due to that spontaneous phase 4 depolarization?
Like the slow upward drift.
Well, with enhanced automaticity, this spontaneous depolarization occurs in tissues that typically don't have this automaticity, or it becomes abnormally accelerated in tissues that normally do. It's like a faulty pacemaker cell popping up where it shouldn't be, or an existing one suddenly going into overdrive.
An unwanted spark plug.
Kind of like that, yes. Pathology. This can happen anywhere that normally exhibits automaticity, the SA node, AV node, his Purkinje system. But critically, it can also arise in pathologic states from other specific regions like the pulmonary veins, the coronary sinus, the superior vena cava, even the ventricular outflow tracts. Injury to the myocardium, maybe from ischemia, lack of blood flow, inflammation. Other things can alter the cellular membrane properties, thereby inducing this automaticity in these typically non-automatic tissues.
Injury can create these hotspots. What are some examples?
Clinically, this mechanism underlies several common arrhythmias. You might see premature ventricular contractions, or PVCs, and automatic idioventricular rhythms, AIVR, often originating from the border zones of infarcted ventricular tissue or in rapidly reperfused ischemic areas. More famously, abnormal automaticity originating in the pulmonary veins is widely believed to be the trigger that initiates episodes of paroxysmal atrial fibrillation. And automaticity elsewhere in the atria can drive various forms of atrial tachycardias.
So it's like an unexpected, unwanted spark that ignites a rapid rhythm from a specific spot.
Correct.
Okay, what's the second mechanism?
The second major mechanism is triggered arrhythmias, which result from after depolarizations. These are abnormal electrical depolarizations that occur after the initial action potential has fired. Think of them as electrical echoes or aftershocks. If these after depolarizations are strong enough to reach an electrical threshold, they can then initiate sustained rapid arrhythmias.
Aftershocks triggering a new earthquake.
A good analogy. There are two main types of after depolarizations. First, early after depolarizations, EADs. Occurrence. EADs typically occur during phases 2 or 3 of the action potential, so before the cell has fully repolarized and reset its electrical charge.
During the reset phase.
Exactly. They're often facilitated by an excessive buildup of calcium inside the cell. Intracellular calcium overload seems to play a key role. Clinical impact. This is really important clinically. When the QT interval on the ECG prolongs, meaning repolarization takes too long, especially if it happens heterogeneously across the ventricles, some areas reset slower than others, these EADs can trigger wavefronts of abnormal depolarizations. This can lead to a very dangerous and chaotic ventricular arrhythmia called torsades de pointe, TDP.
Torsades. That sounds bad.
It is. TDP can be non-sustained or sustained, but crucially, it can quickly degenerate into ventricular fibrillation and lead to sudden cardiac arrest. Predisposing factors. Several things predispose the ventricles to EADs and TDP. These include certain medications known to prolong the QT interval, electrolyte imbalances like low potassium, hypokalemia, and low in magnesium, hypomagnesemia, and even a very slow heart rate, bradycardia. Furthermore, the electrical remodeling that occurs in various cardiomyopathies can also predispose to QT prolongation and the risk of EADs and TDP.
So calcium overload during reset, often linked to long QT, can cause torsades. What's the other type of after depolarization?
The other type is delayed after depolarizations, DADs, occurrence. DADs, as the name suggests, are abnormal depolarizations that occur later during phase 4 of the action potential, after the cell has completely repolarized and returned to its resting state.
And after the reset is complete?
Yes. Mechanism. Like EADs, the underlying mechanism for DADs is often related to increased intracellular calcium concentration. That excess calcium somehow leads to these repetitive abnormal depolarizations during the resting phase. Clinical impact. These repetitive depolarizations can lead to various arrhythmias, including a well-described phenomenon called bidirectional ventricular tachycardia causes. The most commonly described causes for DADs include digitalis glycoside toxicity, an adverse effect of certain heart medications like digoxin, ischemia, lack of blood flow, and exposure to high levels of catecholamines, those stress hormones.
So EADs happen during repolarization. BDs happen after repolarization, both often linked to calcium issues, and both can kick off serious, sustained arrhythmias. Got it. What's the third, and you said perhaps most common, mechanism? The third, and arguably most common and often complex mechanism is reentry, also known as circus movement. This mechanism involves an electrical activation wavefront circulating repeatedly within a defined circuit, like a dog chasing its own tail, but in a never-ending electrical loop.
An electrical short circuit, almost.
In a way, yes. There are two main types of reentry. Anatomic reentry. This occurs around a fixed anatomical barrier. Think of it like electricity flowing around an obstacle, maybe scar tissue from a previous heart attack, or maybe an accessory pathway, that extra electrical connection between the atria and ventricles that shouldn't be there. The circuit has a clear, fixed physical path.
A fixed path around something. Right. The other type is functional reentry. This type occurs around a functionally blocked or refractory barrier or an anchor of tissue that temporarily becomes unexcitable. Unlike anatomic reentry, there isn't a fixed physical barrier here, but rather a dynamic shifting one created by the electrical properties of the tissue itself.
A moving barrier. Okay. What conditions are needed for reentry to happen and keep going?
Good question. The initiation and maintenance of any reentrant arrhythmia require three critical conditions, which Table 243-1 lays out nicely. 1. Unidirectional block. The electrical wavefront must encounter a barrier to conduction that allows it to propagate in only one direction around that barrier or potential circuit. This forces the activation along one limb or pathway while the other limb is temporarily blocked.
One-way street.
Exactly. 2. Slow conduction. There must be a zone within the reentrant circuit where conduction is relatively slow. This slowness is absolutely crucial because it allows enough time for the rest of the circuit, the tissue ahead of the slowly moving wavefront, to recover from its refractory period and become excitable again, ready to be stimulated.
Needs time to recharge it.
Precisely. 3. Excitable gap. This condition is met when the total length of the circuit exceeds a certain distance, which we call the wavelength of tachycardia. The wavelength is basically the conduction velocity multiplied by the refractory period. If the circuit path is longer than this wavelength, it means that by the time the circulating wavefront gets back to its starting point, that tissue has already recovered and is ready to be depolarized again. This creates an excitable gap and allows for perpetual circus movement.
So it's a loop where the signal can only go one way, it slows down just enough in one spot, and the track ahead of it is ready for another pass by the time it gets back around.
Yeah.
That's a powerful concept.
Precisely. And reentry is the mechanism for many clinically important and common cardiac arrhythmias. These include atrial flutter, a rapid, regular atrial rhythm often caused by a large macro-reentrant circuit, typically within the right atrium. AV nodal reentry tachycardia, AVNRT, a very common form of supraventricular tachycardia, where the reentrant circuit is located entirely within or very near the AV node itself. AV reciprocating tachycardia, AVRT. This involves an accessory pathway, that extra electrical connection we mentioned, forming part of the reentrant circuit going between the atria and ventricles, scar-based reentrant ventricular tachycardia, VAT. This occurs when scar tissue from a previous myocardial infarction or other injury creates the anatomical barrier for a reentrant circuit within the ventricles, leading to dangerous fast ventricular rhythms.
So many common arrhythmias use this reentry mechanism. What about that functional reentry you mentioned, the one without a fixed barrier?
Right. Functional reentry, where a dynamic area of partially refractory tissue acts as the anchor for the circuit, tends to result in less stable circuits compared to anatomic reentry. This instability often leads to variations in the speed of the tachycardia and a tendency for the arrhythmia to stop and start spontaneously more easily.
Less stable, harder to pin down.
Exactly. And there's significant evidence that functional reentry is the underlying mechanism for the perpetuation and maintenance of both atrial fibrillation, AF, and ventricular fibrillation, VF.
AF and VF, the really chaotic ones.
Yes. In these seemingly chaotic and disorganized arrhythmias, it's believed that multiple wavefronts resulting from numerous, often migratory functional reentrant circuits are driving the arrhythmia in most cases. It's not just one clear-cut circuit, but a multitude of constantly shifting ones, like little electrical whirlpools. Underlying pathology of the myocardium, things like heterogeneous electrical properties or altered activation and repolarization, significantly predisposes the heart tissue to the initiation and propagation of these functional reentry-based arrhythmias.
That explains why AF and VF can be so challenging to treat definitively. The target isn't fixed, it's constantly shifting and multiple. Beyond these intrinsic cellular and circuit abnormalities, are there external factors that contribute to arrhythmias, things that almost set the stage for them?
Absolutely. In addition to the intrinsic alterations in cellular membrane properties that directly underpin most arrhythmias, extrinsic factors can precipitate other architectural and tissue changes that significantly contribute to proarrhythmia, meaning they create a predisposition to developing arrhythmias.
Like triggers or risk factors?
Exactly. Ischemia and infarction. When heart tissue experiences ischemia, lack of blood flow, or an infarct, tissue death from a heart attack, it can create regions of heterogeneous fibrosis or scar tissue. This results in islands of non-conductive scar surrounded by injured, often electrically irritable tissue. This scarred region creates the perfect anatomical substrate that can sustain anatomic reentry, which, as we discussed, underlies scar-based VT and many macro-reentrant atrial arrhythmias like typical flutter. Also, those peri-infarct border zones, the injured tissue around the scar, often have altered cellular membrane properties that can promote enhanced automaticity or triggered arrhythmias.
So scars create reentry pathways in irritable zone.
Right, chronic ischemia. Even prolonged chronic lack of blood flow can lead to the downregulation of connexin proteins and gap junctions. Remember those crucial connections for rapid electrical communication between heart cells?
The fast connections.
Their downregulation results in slowed impulse propagation. And slowed conduction is one of the necessary factors for reentrant arrhythmias to occur and sustain themselves. Ion channel dysfunction acquired. Beyond inherited mutations, ion channel function can be altered by external factors, most notably certain medications. We touched on QT prolongation earlier. It can occur when the closing of potassium channels is delayed, or when the closing or inactivation of sodium channels is impaired by a drug. This type of acquired ion channel dysfunction can also make the heart prone to dangerous arrhythmias like torsades. So while the mechanisms are internal electrical faults, external factors can certainly flip the switch and make them more likely.
That truly paints a comprehensive picture of what goes wrong when the heart's rhythm is disrupted.
Yeah.
The sparks, the aftershocks, the loops, and the things that make them more likely. So what does this all mean when it comes to fixing these problems? With these complex mechanisms, how do medical professionals approach the treatment of cardiac arrhythmias? What are the main strategies they employ?
This brings us to the fascinating and rapidly evolving field of arrhythmia management. It really employs a multifaceted approach, and understanding the underlying mechanism is paramount because treatments are most effective when they are directly targeted towards those specific physiological abnormalities. The goal is always to try and retune that electrical symphony.
Okay, where do we start? Drugs.
Let's start with pharmacologic therapies, or antiarrhythmic drug therapy. While often the first line, their effects on cardiac electrophysiologic properties are frequently complex and, honestly, in many instances, still incompletely understood.
Complex and not fully understood. Why is that?
Well, this complexity arises from several factors. Complex interactions. Drugs often don't just hit one target ion channel perfectly. They can interact with multiple channels, leading to a broad spectrum of effects, some intended, some definitely not. Variable effects. Even within the same drug class, different drugs can have variable effects on their targets. And how an individual patient metabolizes a drug can drastically alter its effectiveness and side effect profile. What works well for one person might not work or might be toxic for another. Regional differences. A drug might behave differently in atrial tissue compared to ventricular tissue because of those regional variations in ion channel expression we discussed earlier.
Now, that sounds tricky.
It is. And these complexities have unfortunately led to instances of harm from adverse effects over the years. Many antiarrhythmic agents currently in use carry significant, even potentially lethal side effects because they have a narrow therapeutic index.
Narrow therapeutic index means the helpful dose is close to the harmful dose.
Exactly. The dose that's effective is very close to the dose that's toxic. Therefore, their judicious use by physicians with appropriate knowledge and experience is absolutely warranted. The practical result of this is that antiarrhythmic medications are increasingly seen as sophisticated but often ancillary options, especially with the rise of other, more precise therapies like ablation.
So given that complexity and risk, how are these drugs broadly categorized to help doctors navigate their use? Is there a system?
Yes, the traditional nomenclature, the way we've historically grouped these drugs, is the Vaughan-Williams classification schema. It broadly divides antiarrhythmic drugs, or AADs, into four main classes, I through 4. This classification is largely based on their primary ion channel target, as summarized in Table 2432. Think of them as different ways to modulate that electrical spark.
Okay, class I through 4, what do they do?
Let's break it down. Class I AADs. These primarily target the sodium Na plus channel. Remember, that's responsible for the initial rapid electrical spark in most heart muscle cells. They're further subdivided into 3 subclasses, IA, IB, IC, based on how quickly they bind to and unbind from these sodium channels. This affects their potency and duration of action. For example, some class I drugs like lidocaine, IB, are fast-acting, used for things like arrhythmias after a heart attack. Others, like flecainide IC, stay bound longer but have their own risks.
Sodium channel blockers, class 1. Got it, class 2.
Class 2 agents. These consist entirely of beta-adrenergic blocking agents, commonly known as beta blockers. They primarily work by reducing the effects of the sympathetic nervous system activity, the adrenaline effect. By doing this, they slow the heart rate and slow conduction, especially through the AV node. Metoprolol is a common example. Sotalol is interesting here because it's a beta blocker but also has class 3 properties.
Beta blockers, slow things down. Okay, class 3.
Class 3 agents. These primarily target potassium K plus channels. They work by blocking these channels, which prolongs the action, potential duration, and the effective refractory period. Basically, they extend the recharging time of the heart cells, making them less likely to fire too quickly or participate in reentry.
Potassium blockers extend the recharge. Examples.
Specific class 3 agents like sotalol, again, and defibrillators, specifically target a key potassium channel called the HRG channel. While effective, they carry a significant risk of QT prolongation, which, as we discussed, can lead to the dangerous corsuds they point, so they require careful monitoring. Amiodarone is also often considered primarily class 3, but it's complex.
The QT risk.
And class 4?
Class 4 agents. These are the cardioselective calcium Ca2+ channel blockers, including drugs like verapamil and diltiazem. They primarily work by slowing conduction through the AV node and reducing the SA node's automaticity. This makes them effective for controlling heart rate in conditions like atrial fibrillation and for treating certain supraventricular arrhythmias that involve the AV node. Calcium channel blockers, mainly for the nodes. Okay. But you said this system has limitations.
Yes, it's important to understand that the von Williams classification, while traditional and useful conceptually, has significant limitations. Many antiarrhythmic drugs actually interact with multiple ion channels, not just one primary target. As a result, they exhibit behaviors consistent with multiple classes.
Like amiodarone.
Amiodarone is the prime example. It truly exhibits properties of all 4 AAD classes, which likely contributes to its broad efficacy, but also contributes to its notorious potential for multi-organ toxicity with long-term use. This complexity underscores why managing these medications requires deep expertise and careful patient selection.
So even within these categories, there's a lot of nuance. How do doctors try to apply these drugs based on the specific arrhythmia mechanisms we discussed earlier, the sparks, aftershocks, and loops?
The goal is always to try and match the drug to the mechanism, though, again, it's not always perfectly precise due to the drug complexities. For enhanced automaticity-based arrhythmias, those unwanted sparks, the medications used are those that target and slow down phase 4 depolarization. They aim to dampen that spontaneous electrical activity. So this includes calcium channel blockers, beta-adrenergic blockers, which reduce the sympathetic drive-enhancing automaticity, or more specific agents that directly target the funny current in the SA node, like ivabradine.
Dampen the sparks, okay.
For triggered activity-based arrhythmias, those EADs and DADs, the aftershocks, the most effective approach is often to correct the precipitating factor. So therapies might involve removing digitalis glycosides if digitalis toxicity is the cause, discontinuing any QT prolonging medications, correcting electrolyte imbalances, or sometimes even increasing the heart rate slightly with pacing, which can help shorten the QT interval and prevent those EADs.
Fix the underlying cause, makes sense. What about reentry, the loops?
For reentrant arrhythmias, those electrical loops, the strategy is generally to disrupt the reentrant circuit, make it impossible for the loop to continue. One way is to increase the refractory period of the tissue within the circuit. Potassium channel blocking agents, class 3, do this, making the tissue unexcitable for a longer time. The goal is to increase the wavelength of conduction so it becomes longer than the physical length of the circuit path. If the tissue ahead of the circulating impulse is still refractory when the impulse arrives, the circuit breaks.
Make the recharge time too long for the loop.
Exactly. Another approach is to slow conduction velocity significantly within the circuit, primarily using sodium channel blockers, class 1. The idea is to slow the impulse down so much that it essentially extinguishes, it just peters out within the circuit. However, this is tricky. If the drug is only partially effective and only slows conduction somewhat, it can paradoxically shorten the wavelength of tachycardia relative to the anatomical circuit. This can sometimes make the arrhythmia more stable or easier to sustain rather than terminating it.
Oh, so slowing it down could backfire if not done enough.
Potentially, yes. Therefore, for these class A agents, sufficient dosing is often crucial to slow conduction velocity to the point of completely extinguishing the arrhythmia circuit, not just slowing it down a bit.
That's a really deep dive into the pharmacology, which definitely sounds like a delicate balancing act. But you mentioned another major aspect of treatment that has truly revolutionized the field, catheter ablation. How does that work, and how has it evolved from those early, more drastic surgical approaches?
Yes, catheter ablation represents a major leap forward because it offers the ability to mechanically disrupt arrhythmogenic substrates directly, often with remarkable precision and safety. The fundamental rationale is simple. If you can identify and precisely localize the anatomical substrate responsible for an arrhythmia, the exact spot where the problem originates or propagates, then mechanically disrupting or ablating that substrate should eliminate the arrhythmia.
Target and destroy, basically. How did it evolve?
Well, let's trace its evolution. Back in the 1950s and 1960s, as the underlying anatomical substrates for some arrhythmias became better understood, the only interventional, potentially curative therapy available was open surgical disruption. This meant actual cardiac surgery, for instance. Surgeons physically cutting accessory pathways or resecting areas of ischemic scar tissue responsible for VT, but only in highly specialized centers. Hugely invasive.
Right, the open surgery approach.
Then, the first attempts at clinical catheter ablation, doing it through wires instead of surgery, used direct current DC energy. This involved delivering a jarring, powerful pulse of electrical energy through a catheter tip. It would indeed ablate cardiac tissue, but it was very difficult to control the size and depth of the injury. It often led to significant complications like perforation or heart block, making it a less than ideal solution.
DC was too crude.
Pretty much. Then, in the 1980s, radiofrequency, RF energy, was adapted for catheter-based cardiac ablation, and this became, and remains, the current mainstay. Radiofrequency is a form of alternating electrical current. When delivered through a catheter tip to the heart tissue, it causes localized tissue heating, leading to permanent injury or necrosis, essentially creating a tiny, precise burn. For over 35 years now, RF delivery via catheters has been continuously optimized and refined. It's become the most common and cornerstone energy source for catheter ablation procedures worldwide.
So RF ablation, heating the tissue, is the gold standard today. What kinds of arrhythmias can it actually treat, and how does the approach differ for the various mechanisms we discussed, the sparks, loops, etc.?
Catheter ablation is indicated and often highly effective for a wide variety of clinical arrhythmias. This includes most supraventricular tachycardias, SVTs, like AVNRT and AVRT involving accessory pathways, atrial flutter, increasingly atrial fibrillation, AF, problematic premature ventricular contractions, PVCs, and many forms of ventricular tachycardia, VT, especially scar-related VT.
A broad range. How does the strategy change?
The approach really varies depending on the underlying mechanism. For automaticity-based arrhythmias, those unwanted sparks originating from a focal spot, the goal is precise localization and then elimination of that focal source. Using mapping techniques, we find the tiny spot firing too fast and then deliver ablation energy right there to silence it. For anatomic reentrant circuits, those fixed loops around scar or pathways, the strategy is to identify a critical zone of slow conduction within that loop, a bottleneck that is essential for sustaining the arrhythmia and is safe to ablate. Damaging that specific critical zone through ablation effectively breaks the circuit, like removing a bridge on the racetrack, eliminating most reentrant arrhythmias like typical flutter or AVRT.
Break the loop at its weak point. What about functional reentry, like in AF?
That's the challenge. For functional reentry, like what we believe underlies the maintenance of most persistent atrial fibrillation or ventricular fibrillation, mechanical disruption through catheter-based ablation appears to be generally less effective in completely eliminating the arrhythmia long-term. This is because there's often a lack of a fixed anatomical circuit. Instead, you often have multiple migratory circuits that are constantly shifting, making a single targeted ablation difficult or maybe even impossible to catch, completely and permanently eradicate the arrhythmia. Although strategies like isolating triggers, like the pulmonary veins and AF, are very effective.
That makes sense. It's hard to hit multiple moving targets. What about safety during these procedures? You're working inside the beating heart. And what technological advancements have made these procedures even more precise and safer over the years?
Safety is absolutely paramount, of course. The ablation target must be in a location deemed at acceptable risk, carefully avoiding critical structures. We absolutely need to avoid damaging the native conduction system, which could cause permanent heart block requiring a pacemaker, the coronary arteries, or nearby structures outside the heart like the esophagus or the phrenic nerves which control breathing. Precision is absolutely key.
So how do they achieve that precision?
Technological advances have truly revolutionized precision and safety. Electroanatomical mapping systems. These are critical tools, almost like having a real-time GPS system for the inside of the heart. They use sophisticated techniques like measuring alterations in electrical impedance or tracking catheters within magnetic fields to create real-time 3D reconstructions of the cardiac chambers. This allows the electrophysiologist to visualize the catheter's exact position, identify the arrhythmogenic tissue that needs to be targeted targeted, map out the electrical activation, and crucially, safely avoid those non-targeted critical structures. Figure 24234b beautifully illustrates this, showing a 3D map during a typical atrial flutter ablation.
A 3D map of the inside of the heart. Amazing.
It really is. And another key technology is intracardiac echocardiography, ICE. This uses a tiny ultrasound probe on a catheter placed inside the heart to provide real-time ultrasound visualization during the procedure. This allows the operator to directly see the cardiac structures, the catheter tip itself, and its contact with the tissue, further enhancing safety and precision, as also shown in that same figure.
So mapping systems and internal ultrasound give doctors this incredibly detailed dynamic view inside the beating heart. Are there other energy sources besides radio frequency being used for ablation today? You mentioned RF is the mainstay, but are there alternatives?
Yes, absolutely. While RF heating is the workhorse, alternative ablative energy sources have been explored and are increasingly used in clinical practice, each with its own potential advantages and disadvantages. Cryothermy. This is probably the most widely applied non-RF ablative energy source today. Instead of heating, it uses extreme cold. An ablative catheter tip is cooled to a very low temperature, typically below -40 degrees Celsius. This results in permanent tissue death through ice crystal formation and subsequent cellular damage. Cryothermy is very widely applied to the ablation of paroxysmal atrial fibrillation, particularly for creating circumferential ablative lesions around the openings of the pulmonary veins into the left atrium, often using an expandable balloon catheter that freezes a whole circle at once. Figure 243.4b provides an image of this cryoballoon in place.
Freezing instead of burning. Any advantages?
One potential advantage of cryothermy is that it may be safer near certain critical nerves, like the phrenic nerve. The cold lesion seems less likely to cause permanent nerve damage compared to heat, and you can often test nerve function during a temporary freeze before making it permanent.
Interesting. Any other newer technologies?
Yes, there are several newer and emerging technologies generating excitement. Pulsed field electroporation, PFE. It's a very hot topic right now, a non-thermal ablation modality that's gaining significant traction. It injures targeted myocardium through high-energy, ultra-short pulses of electrical current. Unlike thermal ablation, RF or cryo, PFE selectively disrupts the lipid cell membrane through a process called electroporation, leading to permanent cell death. A key potential advantage is its tissue selectivity. It seems to preferentially affect heart muscle cells while sparing adjacent tissues like nerves and the esophagus, potentially offering an even safer profile.
Electroporation sounds futuristic.
It feels like it. Another one is stereotactic external beam ionizing radiation. This is a technique borrowed from oncology, where highly focused beams of radiation are used to treat tumors. It has recently been adapted and applied non-invasively to the heart to treat certain refractory arrhythmias, including some forms of ventricular tachycardia and potentially atrial fibrillation. This modality holds immense promise because it's completely non-invasive, no catheters inside the heart, theoretically lower risk in some ways, and crucially, it might be able to target regions of the heart, like deep myocardial scars, that may be difficult or impossible to reach effectively with traditional catheters. Still early days, but very promising.
That's incredible. From precise burns to freezing, electrical pulses, even non-invasive radiation, the toolkit available today is incredibly diverse and sophisticated. Okay, what about the other major interventional arm? You mentioned the implanted devices. How do pacemakers and defibrillators fit into this treatment picture?
Yes, implanted cardiac rhythm management devices, pacemakers, and ICDs are an absolute cornerstone of managing arrhythmias, particularly for bradyarrhythmias, too slow, and for preventing sudden cardiac death from tachyarrhythmias, too fast.
Let's start with pacemakers. They're for slow heart rates.
Primarily, yes. The first definitive implantable pacemaker went in way back in 1958, and this technology has evolved tremendously since then. They've become the absolute mainstay in the long-term management of bradyarrhythmias. Indications. The main reasons someone gets a pacemaker are typically symptomatic sinus node dysfunction when the heart's natural pacemaker is too slow or unreliable, or AV conduction disease when the electrical signal can't get from the atria to the ventricles efficiently, especially when these conditions cause symptoms like dizziness, fatigue, or fainting.
How are they put in?
Pacemakers are typically implanted percutaneously, meaning through the skin, without open surgery. Conductive and sensing wires, called leads, are inserted through the venous system, usually starting from a vein in the upper chest or shoulder area. These leads are then carefully guided using X-ray into the right atrial and/or right ventricular myocardium, the heart muscle. The tip of the lid is then actively or passively secured to the heart muscle. These leads are connected to the pulse generator, which contains the electronic circuitry and a long-lasting battery. The pulse generator, often called the can, is typically placed in a small pocket created in the prepectoral space just under the skin below the collarbone.
Wires in the heart, battery under the skin. What does it do?
The pacemaker's function is exquisitely designed. It constantly senses the heart's own intrinsic electrical activity. If the heart beats on its own at an adequate rate, the pacemaker just watches. But if the heart rate drops below a programmed threshold, or if a beat doesn't come when expected, the pacemaker delivers precisely timed, tiny electrical pacing stimuli to make the heart contract, ensuring an adequate heart rate is maintained.
Senses and paces only when needed. Smart. Are there leadless options now?
Yes, that's a significant recent development. A completely leadless pacemaker has become available. This is a tiny, self-contained device, like a small capsule, that's inserted through a catheter, usually via a large vein in the leg, the femoral vein, and implanted directly into the right ventricular endocardium, the inner lining of the right ventricle. It has no leads running through the veins.
Wow, just the capsule inside the heart.
Exactly. While these devices currently offer more limited pacing options, typically only pacing the right ventricle, not coordinating with the atrium yet, they significantly reduce the risks associated with traditional transvenous lead systems. Risks like lead infection spreading through the bloodstream, lead fracture over time, or the need for complex and risky procedures to extract leads if they malfunction or get infected. It's a great option for certain patients.
Fewer complications. Makes sense. Okay, what about the other devices? ICDs? Implantable cardioverter defibrillators.
Right, ICDs. These devices are often placed in a similar fashion to traditional pacemakers, typically with transvenous leads going into the heart chambers function. However, ICDs have a much more advanced and critical capability beyond just pacing for slow rates. They can precisely sense abnormal ventricular arrhythmias, particularly those that are fast, chaotic, and life-threatening, like ventricular tachycardia, VT, or ventricular fibrillation, VF.
They detect the dangerous fast rhythms.
Yes. And when they detect one, they can respond in two main ways. First, they might deliver anti-tachycardia pacing, ATP. This is a rapid burst of low-energy pacing pulses delivered even faster than the tachycardia, designed to interrupt the abnormal circuit and restore normal rhythm, much like trying to electrically reset the heart. If ATP doesn't work, or if the rhythm is immediately life-threatening like VF, the ICD can then deliver a high-energy defibrillation shock to essentially stun the heart and allow its normal rhythm to restart. In patients who experience a potentially lethal ventricular arrhythmia, ICD therapy can be literally life-saving.
A shock to reset the heart.
Yeah.
Who gets these?
Indications for ICD therapy are generally considered for either primary prevention. This is for patients who have not yet had a life-threatening arrhythmia, but are considered at high risk for sudden cardiac death, SCD, based on their underlying heart condition. For example, someone with very poor heart function after a heart attack, or someone with certain inherited genetic conditions that predispose them to VT or VF, secondary prevention. This is for patients who have already survived an SCD event, like cardiac arrest, or have had documented sustained VT or VF. For them, the risk of recurrence is high, and the ICD acts as a safety net.
Preventing it before it happens or after it's already happened once. Is there a leadless version of ICDs too?
There's a variation, yes. A completely subcutaneous ICD-SACD system has become available. This system avoids intravenous leads altogether. The main defibrillation lead is placed just under the skin, over the sternum and rib cage, not inside the heart or blood vessels. The pulse generator is typically placed under the skin on the side of the chest.
So nothing inside the veins or heart.
Correct. This significantly reduces the risk for bloodstream infections associated with transvenous leads and eliminates the need for potentially complex procedures to extract leads later on. It's an important innovation, especially for younger patients or those at high risk for infection. It doesn't provide ATP or pacing for slow heart rates like a transvenous ICD can, but it offers effective defibrillation without the lead-related risks.
It's astounding how far treatment has come from open heart surgery to tiny smart devices inside the heart, leadless options, and incredibly targeted energy delivery. Now, before we wrap up our deep dive into these principles, let's talk about the diagnostic process itself. What stands out to you as the most critical steps in how doctors actually figure out what's happening when someone experiences an arrhythmia? How do they play detective?
That's a great way to put it. The evaluation of a patient with a suspected arrhythmia is definitely a comprehensive and iterative process, much like detective work. It always begins with a directed history, a thorough physical examination, and critically, a 12-lead resting ECG. These initial steps are the absolute foundation.
The history and exam, what are they looking for specifically?
The history and examination are paramount for gathering vital clues. They need to focus on several key areas. Nature of symptoms. As we touched on, arrhythmia symptoms can vary wildly. They can be vague fatigue, general chest pain, shortness of breath, dyspnea, lightheadedness, or more specific, feeling a rapid, slow, or irregular heart rate. Patients might describe premature contractions, PVCs or PACs, as extra beats, flutters, or sometimes if the extra beat leads to a less effective pump, they might feel it as a skipped or missed beat followed by a stronger one.
So pinning down the feeling.
Exactly. And importantly, hemodynamic sequelae. We need to know if the arrhythmia is causing reduced cardiac output. This can lead to more serious symptoms, ranging from presyncope, feeling faint like you might pass out, to frank syncope, actually losing consciousness, profound shortness of breath, crushing chest discomfort, or generalized weakness. Also, the cadence and duration of episodes are key. Are they brief flutters or sustained racing for hours? Highly variable.
How bad does it make them feel?
Right. And critically, underlying compromise. In patients who already have structural heart disease, an arrhythmia causing even a modest drop in cardiac output can trigger or worsen symptoms of their underlying condition, like bringing on angina, chest pain from poor heart blood flow, worsening congestive heart failure symptoms, or causing hypoxia-related symptoms.
The arrhythmia interacting with other heart problems.
Precisely. We also look for inciting factors associations. Asking about triggers can provide crucial clues. Are the symptoms associated with increased adrenergic tone provoked by exercise, caffeine, stimulants, intense emotional stress? That might suggest certain tachyarrhythmias, especially those driven by enhanced automaticity. Conversely, a detailed medication history is vital. Are they on calcium channel blockers or beta blockers that might be causing or worsening bradycardia? Are they on any medications known to prolong the QT interval, raising concern for torsades?
Triggers and medications. What else?
Family history. A thorough family history is essential, not just asking about known arrhythmia diagnoses, but specifically about unexplained sudden death in relatives, especially at a young age. This can strongly suggest an inherited arrhythmia syndrome pointing towards a genetic predisposition. Demographics. Even demographic factors can provide diagnostic hints, believe it or not. For example, atrial fibrillation is quite rare in children and young adults unless they have significant structural heart disease or a rare familial form. Brugada syndrome, a dangerous inherited channelopathy, has a strong male predominance and is more prevalent in individuals of Southeast Asian descent. Inappropriate sinus tachycardia is seen almost exclusively in young women. And degenerative conduction system disease causing symptomatic bradycardia is naturally most common in older patients.
Age, gender, ethnicity can all be clues. Fascinating. What about prognosis?
Discerning patient prognosis early on is a critical aspect of the initial evaluation. It really informs the aggressiveness of further testing and treatment. Generally, arrhythmias that result in more significant hemodynamic compromise, like causing fainting or severe heart failure symptoms, tend to correlate with more malignant or dangerous underlying disease. Loss of consciousness, syncope, is a particularly challenging yet common diagnostic dilemma. It can be caused by a dangerous cardiac arrhythmia, but it also has many more benign causes, like simple fainting. However, the presence of underlying structural abnormality of the ventricular myocardium generally raises the suspicion for more malignant arrhythmias, both because the damaged ventricle is more prone to generating lethal rhythms and because it might not tolerate any arrhythmia well hemodynamically.
So it's careful detective work right from the start, gathering every possible piece of information, every clue. After that comprehensive history and physical, what's the next fundamental step for pretty much every patient?
The ECG. The 12-lead resting ECG is truly the cornerstone and arguably the most important initial diagnostic test for every patient with suspected arrhythmia. It can offer immediate clues.
How so?
Well, most simply, if an active arrhythmia happens to be captured on the ECG while it's being recorded, a definitive diagnosis can often be made right then and there. Problem solved, at least diagnostically.
Catching it in the act.
Exactly. But even if the rhythm is normal during the ECG, it can provide crucial evidence of underlying cardiac disease that predisposes to arrhythmias. Things like signs of a prior myocardial infarction, Q waves, left ventricular hypertrophy, thickened heart muscle, patterns suggestive of hypertrophic cardiomyopathy, evidence of atrial enlargement, or baseline conduction system disease, like bundle branch block. All of these raise suspicion. The ECG can also point directly to specific conditions known to cause arrhythmias, like ventricular pre-excitation, the delta wave of Wolff-Parkinson-White syndrome, a prolonged or shortened QT interval, or the characteristic ECG findings suggestive of specific inherited conditions like Brugada syndrome or arrhythmogenic right ventricular cardiomyopathy, ARVC.
So even a normal ECG can hold clues. But what if the arrhythmia isn't happening right then?
That's the significant limitation. A standard resting ECG typically records only about 6 to 10 seconds of cardiac electrical activity. It's just a brief snapshot in time. Therefore, many intermittent and transient arrhythmias, particularly those not associated with abnormalities on the resting ECG between episodes, may simply not be captured. Many arrhythmias can only be definitively diagnosed if an ECG is performed during an active arrhythmia episode or during symptoms, or if the arrhythmia can be provoked in a controlled setting.
That makes perfect sense. If the arrhythmia isn't happening when they're hooked up, you won't see it. So how do doctors catch those elusive intermittent arrhythmias that come and go unpredictably?
That's where ambulatory monitoring comes in. These are devices designed specifically to capture transient arrhythmias over longer periods, hours, days, weeks, even years. The most appropriate monitoring option is guided primarily by the cadence or frequency of the suspected arrhythmia episodes or symptoms. If a patient experiences symptoms pretty much daily, then a 24 or 48-hour continuous Holter monitor is often appropriate. This is a small recorder worn by the patient that records every single heartbeat continuously for that entire period. It gives a very comprehensive short-term view.
Daily symptoms, Holter monitor. What if symptoms are less frequent?
If symptoms happen, say, weekly or monthly, a longer-term event recorder might be used. Some of these require the patient to push a button when they feel symptoms to store the ECG rhythm around that time. Others, called mobile cardiac telemetry or MCT, monitor continuously and automatically detect and transmit abnormal rhythms.
Patient-activated or automatic detection. What about fainting, syncope?
Right, a patient-activated event recorder would be inappropriate for someone experiencing syncope. If they lose consciousness, they obviously can't activate the device. By the time they reawaken, the arrhythmic event may have already passed. For very infrequent events, especially unexplained syncope happening maybe only a few times a year, tiny implantable loop recorders, ILRs, might be considered. These tiny devices are injected just under the skin and can continuously monitor the heart rhythm for months or even several years, passively waiting to capture that rare but potentially crucial event.
Implanted monitors for rare events.
Okay.
Are there times when doctors try to intentionally provoke an arrhythmia to capture it or understand its mechanism better in a controlled environment?
Yes, absolutely. Provocative testing may be warranted in appropriate circumstances, always performed carefully and safely, of course. An ECG-monitored treadmill test, stress test, can be used to try and elicit exercise-induced arrhythmias that only appear with physical exertion. It can also be helpful if long QT syndrome is suspected, as in these patients, the QT interval might paradoxically fail to shorten appropriately with the increased heart rate during exercise, which is an important diagnostic clue. Pharmacologic provocation might be indicated for certain suspected diagnoses like Brugada syndrome. Specific drugs, like sodium channel blockers, can be administered intravenously under close monitoring to try and temporarily unmask the characteristic ECG pattern that might otherwise be hidden at rest. Carotid sinus massage, gently massaging the carotid artery in the neck, or other maneuvers designed to enhance vagal tone, like the Valsalva maneuver, can be judiciously and appropriately used in the right setting to help diagnose carotid sinus hypersensitivity or overall vaguely mediated syncope, where the vagus nerve overreacts and significantly slows the heart or causes pauses.
Stress tests, drug challenges, vagal maneuvers. What about tilt table testing? I've heard of that for fainting.
Yes, historically, tilt table testing, TTT, was used more frequently. This involves strapping a patient safely to a tiltable table and then rapidly moving them from a flat supine position to an upright position while continuously monitoring their heart rate and blood pressure. In patients with suspected autonomic dysfunction causing syncope or presyncope, this provocation aims to elicit a paradoxical, abnormal vasogal response, resulting in sudden bradycardia, sinus pauses, a drop in blood pressure, hypotension, and potentially reproduction of their fainting symptoms.
Trying to make them faint safely. Does it work well?
Well, that's the issue. Given a significant lack of both sensitivity, it misses many cases, and specificity, it can be positive in people without the condition. Demonstrated in more recent studies, the current role of TTT is actually quite unclear. It has largely fallen out of favor as a primary diagnostic tool for syncope in many centers, though it might still have a role in specific situations.
Okay, so tilt table is less common now. That sounds like a pretty rigorous diagnostic pathway, already combining careful observation with ambulatory monitoring and sometimes targeted convocation. But for some arrhythmias, especially those that are complex, potentially dangerous, or might require an intervention like ablation, I imagine they need to go even deeper to pinpoint the exact electrical fault, right?
Absolutely. For many complex or critical arrhythmias, invasive electrophysiologic testing, or an EP study, is considered the nearest we have to a gold standard diagnostic modality. It provides an unparalleled level of detail about the heart's electrical system.
The EP study, going inside again, what does that involve?
It's a catheter-based procedure. Specialized, very thin electrode catheters are placed within the heart chambers, typically accessed via veins and sometimes arteries in the groin or neck. These catheters record incredibly detailed intracardiac electrograms. These are highly precise electrical signals recorded directly from within the heart chambers, far more granular and informative than what a surface ECG can show. We can see exactly when different parts of the heart are activated.
Seeing the electricity flow from the inside, what else happens?
During an EP study, baseline conduction properties are meticulously measured how fast signals travel through different parts of the conduction system. Then, a variety of precise provocative maneuvers are performed. These include carefully controlled electrical pacing maneuvers from different locations within the heart and programmed electrical stimulation delivering precisely timed electrical impulses to test the heart's circuitry and its susceptibility to arrhythmias. Sometimes pharmacologic provocation with drugs might also be used during the study.
Trying to trigger the arrhythmia.
Exactly. The ultimate goal is to safely and reproducibly elicit the patient's clinical arrhythmia in the controlled lab setting and precisely define its underlying mechanism, automaticity, reentry, triggered. The nature of the arrhythmia elicited and how easily it's induced can also provide critical insights into the patient's prognosis and guide therapy.
So it's diagnostic and prognostic. Is it mostly done alongside ablation now?
Yes. In the modern era, the vast majority of invasive EP studies are performed in conjunction with a planned catheter ablation procedure. The EP study during ablation serves multiple crucial purposes. It confirms the diagnosis just before ablation. It precisely localizes the appropriate ablation target, those critical circuits or focal sparks using those mapping systems we discussed. And then, after the ablation is performed, it rigorously evaluates the efficacy of the ablation, making sure the target arrhythmia can no longer be induced. While its primary role has heavily shifted towards guiding ablation, programmed ventricular stimulation during an EP study for risk stratification of sudden death is still occasionally utilized in specific, carefully selected, high-risk patient groups.
A powerful tool, especially combined with treatment. Beyond all these electrical tests, what other imaging or testing might be needed to get a full picture of the patient's heart? The structure, not just the electricity.
That's a crucial point, because structure and electrical function are intimately linked. Depending on the suspected arrhythmia diagnosis and the patient's overall clinical picture, further advanced imaging and testing for underlying structural heart disease are often indicated. Echocardiography, an ultrasound of the heart. This is most often the first and best next test if structural heart disease is suspected. It's great for assessing underlying structural abnormalities, like valve problems or thickened walls, evaluating left ventricular function, how well the main pumping chamber squeezes, assessing atrial dimensions, important in conditions like atrial fibrillation, and evaluating heart valve function more generally.
Echo first for structure. What else?
Cardiac CT and cardiac MRI offer even more detailed anatomical and tissue information. They have broad diagnostic utility. Cardiac CT is excellent for evaluating coronary artery disease non-invasively, identifying certain congenital anomalies, assessing the extent and location of ventricular scar tissue, and providing highly detailed 3D mapping of complex left atrial anatomy, which is crucial for planning AF ablation procedures. Cardiac MRI provides significantly higher resolution for soft tissue characteristics. It's often the gold standard for precisely assessing areas of ischemia, lack of blood flow, myocardial infarct, scar tissue from heart attack, various types of cardiomyopathy, heart muscle disease, or infiltrative diseases where abnormal substances accumulate within the heart muscle, like amyloidosis or sarcoidosis.
CT and MRI for detailed anatomy and tissue type. Anything else?
Cardiac PET, positron emission tomography, can go even further in some cases. It can help discern underlying ischemia, but also provides unique functional insights at a molecular level, looking for metabolic abnormalities, inflammation, or infiltrative conditions affecting the heart. Together, these advanced imaging tools help paint a complete picture of the heart's structure and tissue health and how those factors might be contributing to the electrical problem being investigated.
Wow, okay. From the smallest cellular details, those tiny dancing ions and protein gates, up through the complex reentrance circuits, and then the incredible, evolving array of diagnostic tools, sophisticated pharmacological interventions, and advanced ablation and device therapies, this deep dive has truly unpacked the core principles of clinical cardiac electrophysiology.
It's a lot to cover, definitely.
It really is.
Yeah.
And understanding these principles isn't just about, accumulating facts. It feels like gaining a powerful, empowering insight into one of the most vital and beautifully complex systems in the human body. So what does this all mean for you, our listener? Whether you're a student, a healthcare professional, or simply immensely curious about how your own body works, grasping this material with the depth of an expert gives you, I think, a much deeper appreciation for the marvel of the human heart and the incredible advancements in medicine that help keep its vital rhythm beating in perfect time.
And maybe this raises an important question for us to ponder as we finish. Despite the truly astounding advancements we've discussed today in understanding and treating heart rhythms, mapping circuits, ablating targets, sophisticated devices, the heart's electrical system still holds profound mysteries, particularly when we talk about the really complex and widespread arrhythmias like persistent atrial fibrillation and ventricular fibrillation.
Still mysteries to solve.
Absolutely. We've come incredibly far in defining ion channels and electrical circuits, but what about the next frontier? You have to consider how future technological advancements, maybe in AI-driven diagnostics that can analyze subtle patterns and predict arrhythmias before they even manifest, or perhaps truly biointegrated therapies that seamlessly interface with the body's own electrical systems in ways we can barely imagine now, might further revolutionize the field, taking us beyond our current understanding of these precise, albeit sometimes still elusive, electrical circuits. The journey of discovery here is definitely far from over, and the future of cardiac electrophysiology is certainly one to watch.
A truly thought-provoking note to end on. A great reminder that even with such incredible knowledge packed into fields like this, there's always more to learn, more to discover. Thank you so much for joining us on this incredibly detailed deep dive into cardiac electrophysiology. Keep exploring, keep learning, and stay curious. We'll see you on the next deep dive.